official clinical pregnancy after more than 3 unsuccessful transfer of high quality embryos, after more than 3 transfer of high quality embryos, or after a cumulative transfer of more than 10 embryos. That is national definition. The British Fertility Society says absence of positive pregnancy test after 3 consecutive transfer of good quality embryos. Incidence of recurrent implantation failure is almost 10 to 15%, and recurrent pregnancy loss affects 1 to 2% of the reproductive age group women. We are going to focus on the recurrent implantation failure, that is 10 to 15% of age of patient we are facing day in and day out. The paradox, the conceptus contains 50% genes from the father and 50% from the mother. So theoretically it should be rejected by the maternal immune system because the baby is growing inside the mother. So theoretically it should be rejected, but the rejection doesn't occur every time. Why? Because we have that medical hypothesis, it was done in 1953. Is there an anatomical separation of mother and fetus? Is the uterus immune pervaded site? Or is there a weak or absent expression of fetal antigen? The conceptus immunological invisible? Or suppression of maternal immune response? Is the maternal immune response compromised? No. The immune system is activated and aware of the fetal antigen. And immune cells and mediators involved in all the reproductive events are there. So we have to be very clear that the immune system is active. The mother immune system is not inactive. It is very much active. And immune cells and mediators are involved in all the reproductive events. Immune flexibility, the tolerance versus rejection, the capacity to discriminate foreign or non-self from the self, dangerous, either it is a tolerance or there is a rejection. That is the basic thing. Either the baby is accepted or the baby is rejected. There are different forms of immune response. When we are talking about tolerance, we have to think of Treg cells, we have to think of M2 macrophages, dendritic DC and NK cells, which are CD56 bright cells. All these cells are anti-inflammatory. On the other side is T1Th, T clonova cells, M1 macrophages, or cytotoxic CD56, which are the dimmer cells. All these are pro-inflammatory. In pregnancy, the immune response is tolerance, towards the tolerance. If you look on the right side, the green, all the cells, they are the tolerance cells. That is why the pregnancy is continuing. We are going to talk about immunodoption commencing before implantation. It is an essential element of endometrial receptivity. Treg cell is implying implantation and pregnancy loss. Will the intervention targeting Treg cell be helpful? And will potential for immune regulatory drugs intervention in early pregnancy loss? The immune response begins at conception. We have to be very clear that the immune response is beginning at conception itself, and permissive response at implantation is very essential. And if you remember, it contributes to the endometrial biosensor. The endometrial cells, after dysregulation, they become biosensor. They will either promote the implantation of a healthy embryo or they will reject an unhealthy embryo. So it sets the trajectory for robust placental development and healthy pregnancy progression. Immune cell changes accompanying the acquisition of endometrial receptivity. So as the endometrium receptivity grows, the immune cell changes also happen. The Treg cells are the master regulator of endometrial immune network. Treg cell can give us T helper 1 to T helper 17. They can give us cytotoxic NK cell. They can give M1 macrophages, or they can give us telorogenic DC dendritic cell or lutein active. So basically it is Treg cell which is the master regulator. They can produce any of the subset cells. And Treg cells are essential for embryo growth and implantation in early pregnancy. If the Treg cell depletion occurs in early pregnancy, day 1 to day 3, it is implantation failure. It is happened from day 5 to day 8. It can be increased miscarriage. If it happen later on days 11 to day 14, there is susceptibility of loss. So basically, if the Treg cell depletion occur, there is chances of failure to happen, either it can be implantation failure or miscarriage. The immunological physiology of embryo implantation, this is the older theory, the embryo is, there is apposition, then finally there is attachment, and then the invasion, the embryo invades into the endometrium. And once the implantation happens, the immune system is also active at that time. The critical step for a successful implantation, it depends upon the embryo quality, endometrial receptivity, and embryo maternal microenvironment. Basically, if you see the picture on the left side, by the time it is day 8 or day 9, it is the implantation of the blastocyst which is happening. So, implantation is the most critical step in the whole process. And to achieve a successful implantation, you have to have a creation of uterine environment of appropriate endometrium receptivity, trophoblast proliferation, and embryo nesting. All these cells, all these changes are happening for achieving a proper implantation. Immune response during pregnancy, either it can be embryo-protective immunomodulation. The picture on the right side, there is a normal pregnancy, progesterone receptor activation, progesterone-induced blocking factor, which can shift the cascade to the T helper 2 type, and which are embryo-protective immunomodulator, and pregnancy continues. On the left side, if there is a cascade reaction, the T helper 1 cell response is activated, TNF factor and interleukin 2 are produced, natural killer cells are there, lymphokinin activity, killer cells are there, and there is abortion of the fetus. So these are the things which can happen. Normally we are looking for the embryo protection, which is on the right side. The T2 helper cells are predominant. Again, to look at this receptivity require a bias toward T cells, appropriately active uterine NK cells, anti-inflammatory macrophages, and telomeric DC cells. These are all required for a active receptive endometrial receptivity. Implantation failure is happening if there is a shift of the phenotype with a bias toward T cells, toward overactive or underactive uterine NK cell, and proliferative macrophages and immunogenic DC cells. DC cells are basically dendritic cells, but if you see the picture on the left side, that is influencing the receptivity. Once you have more of the T cells and underactive or overactive NK cell, you have picture on the right side which causes infertility. The role of Treg cell, I already mentioned that adequate Treg cell number and function is needed to have this cytotoxic attack, and Treg cell depletion lead to insufficient suppression and increase in inflammation. What are the pathophysiological role of immunological factor? Look at the top: cytokine imbalance, expansion of peripheral natural killer cells, and dysregulation of uterine natural killer cells. These are the important factors of the immunological factor in recurrent implantation failure. The pathophysiological role of various factors in RIF: disrupted endometrial receptivity, altered expression of genes, immunological disturbance in peripheral blood, epigenetic alteration, and immunological disturbance like altered Th1 and Th2 ratio, altered NK cell and macrophage numbers. These are the recurrent implantation, the various factors: infection, genetic factor, thrombophilia, uterine factor, male factor, embryonic factor, lifestyle factor, and lastly what we are going to focus was the immunological factor. Either there is altered T1-Th ratio, or there is a altered NK cell phenotype or numbers. The diagnostic workup, when you are thinking of recurrent implantation failure, you have to think of the immune profile, and we have to check for the NK cells, the macrophages, T cells. NK cell, almost 70% are responsible for the implantation, macrophages 20%, and T cells are for 20%. The depletion of immune cell and maternal fetal interface has been determined effect on survival of fetus. The role of uterine natural killer cell, there are two types. One is a peripheral blood natural killer cell level, the CD56 dim and CD16 plus are seen in IVF failure, are significantly higher, those who are successful IVF. The uterine natural killer cell, the density of uterine natural killer cell in an endometrium with women with RIF after IVF is significantly higher than in an endometrium of women with control group. Ladies and gentlemen, I want you to focus on this slide. This is the comprehensive lymphocyte subset analysis. This is done in very few labs. We have a lab in Delhi, Dang lab, which is doing it. Now other labs are trying to do it. This is how we, in a patient of recurrent implantation failure, we look for the CD4 count, the T cell subset, which can be T helper 1, T helper 2, T helper 17, or T Treg cells. Then we can do CD56 for NK cell, whether it is dim or bright. So the last column rows shows the biological reference, the interval, the biological reference ratio, presence of the cells in a normal woman. So the cell must be in that particular range when you are doing the test. This test costs around 11,500 rupees, but this is what is needed when we have a patient of recurrent implantation failure. The CD4 T cells and NK cells is out of the total lymphocyte, while the T cell subset like Th1, Th2, Th17 is out of the total CD4 count. NK cells are further studied as per CD56 bright or dim. An increase in Th1 or Th2 ratio and reduced T regulatory cell during pregnancy is associated with increased complication of recurrent pregnancy loss. That is why we would like to check what is the level of these T cells. The role of cytokinins. The cytokinins are essential contributing factors. They are being secreted by uterine natural killer cell. The cytokinins and growth factors are IL-1 beta, IL-2, IL-4, IL-6, IL-8 and IL-10. And they are also producing angiogenic growth factors, VGF-A, VGF-C. And there are some proteolytic enzymes also required, MMP1, MMP2. And the role of T cell is cytokines are critical in guiding the development and differentiation of CD4 T cell subtypes. Cytokinins in recurrent implantation failure and recurrent pregnancy loss. The cytokine storm can happen in excessive and uncontrolled release of pro-inflammatory cytokinin by the immune system, leading to systemic inflammation and tissue damage. And in the context of recurrent implantation failure, a localized version of this immune dysregulation can also occur. This is what is happening on the left side. In the recurrent implantation failure, the cytokine storm is happening at the local level of the site of implantation. And in case of recurrent pregnancy loss, it is happening in the placental tissue where the cytokine storm is happening. Immune cells and receptivity of embryo implantation, the timely shifting of T1 to Th2 and Treg cell balance is of utmost importance for successful pregnancy. So this is very important that the shifting of Th1 to Th2 and Treg to Th17 is of very important how it should happen during the implantation phase. We all know from all this discussion, either the woman is fertile or woman is infertile, either because of the immune imbalance which has happened or there is a weak response. The immune response has happened but it is weaker. Underlying causes of immune imbalance, we have environmental pollutant, medication, sleep, age, genetics, diet, nutrition, and metabolism. A causal link between metabolic dysfunction and Treg cell insufficiency is very much there. And the cause of a weak immune system is age, vitamin or micronutrient deficiency, endometriosis, environmental toxins, shift work, psychosocial stress, prior oral contraceptive pills, or prior priming to conceptive antigen. All this cause a weak immune response, but the patient will remain infertile. Now you have immune modulating intervention, which one to pick? We have many intervention available to us: corticosteroid, tacrolimus, TNF inhibitor, IVIG, intralipid, progesterone, cytokinin, GCF, interleukin. So we have to choose. Either we look at the immune balance and whether there is a tolerance or inflammation. Look at this slide. This was, I took out from Dr. Sarah Robertson lecture. The keynote address was there in IFS 2025 in Tokyo. According to this slide, either the patient is imbalanced or a weak response. Imbalance is when there is pro-inflammatory the corticosteroid, tacrolimus, TNF inhibitor can improve, and in a weak response, all these things can worsen the condition. So you have to be very selective which modality to use. Similarly, IVIG, intralipid progesterone can improve the weaker response group, but not the pro-inflammatory group. The various drugs used in recurrent implantation failure, intralipid acting on elevated NK cell, tacrolimus acting on TH1, TH2 immune response, TNF alpha inhibitors, IVIG, hydroxychloroquine, endometrial scratching. The Thymosin Alpha is acting on the like tacrolimus on TH1, TH2 immune response and act on the antiphospholipid antibody. The current therapy shows limited efficacy and need for targeted immunomodulation. What is Thymosin Alpha? It is a recognized as alternative therapy which is secreted by thymus gland and consists of 28 amino acids, and it is added in the modulation of innate immunity via pleiotropic property. Basically, there is feedback inhibition of cytokine production. It dampens the immune response to prevent cytokine storm, and it restores the immune hemostasis. So it is rapidly absorbed with the serum level reaching within 2 hours, and a dose proportion increase is seen in serum level, and serum level return to basal level by 24 hours. So that is why the doses has to be repeated every 24 hours. The safety of Thymosin Alpha, it is available since 1979, and lot of patients have received for various immunological modification. It has been used in elderly patient and even younger children also, and it can be used for even 12 months without any significant adverse effect. It is decrease level of it is associated with pre-consumption endocrine or immune disturbance preceding this thing. Low pre-conceptual maternal serum Thymosin Alpha are seen in belated pregnancy. This was published. Then another paper published, uterine immunological changes may be responsible for repeated implantation failure. Modulation immune system is shifted to inflammatory response as peripheral NK cell TH17 signaling pathways are activated. Cytokine expression in endometrium movement with implantation failure and recurrent miscarriage. The cytokine play a role in controlling endometrial decidual cytotrophoblast, and cell function, therefore defect in expression of cytokine is there. All these are publication. This one a recent publication. Basically, when you are giving Thymosin Alpha, how does it affect? It increases the Treg cell on the right side. It corrects the ratio favoring pregnancy. The CD56 and CD57 counts are decreased. PDI1 is decreased. PDI-L1 is also decreased. Treg cells are increased. This is how the Thymosin Alpha act. The dosing scheme, it was previously proposed. Then we have an advisory meeting, and we all decided because the level is going to basal level within 24 hours, it is better to give it every day. So now, next, when you have this dosing schedule, you will see that it will be given every day from day 1. What is when you are giving this immune therapy, you have to weigh against the maternal and fetal side effect. You must always remember the lowest effective dose during first trimester has to be given, and you have to always regularly evaluate your patient. It's not that you have started the medicine